Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health, finance, and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, kidney transplantation, and we've got 2 guests this week, Dr. Catherine Staffeld-Coit and physician assistant Emily Grant. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 866-3200, and we'll be putting up the number at the bottom of our screen when we get to that point. And by email, you can email your questions to us at hhquestions@wlae.com. We'll ask you to hold off on the calls for now, but you can send the emails to us at hhquestions@wlae.com right now. Well, Dr. Staffeld-Coit attended medical school and did her residency at Northeastern Ohio University's College of Medicine in Rootstown, Ohio. Her internship was at Akron City Hospital. Her fellowships in clinical renal nephrology research and renal transplantation are from the Emory University School of Medicine in Atlanta. Dr. Staffeld is board certified in internal medicine and nephrology by the American Board of Medical Examiners, and she is a fellow of the American College of Physicians. She's been at Ochsner and part of the team since 1996. Ms. Emily Grant is a physician assistant at Ochsner. She received her Bachelor of Science from Physician Assisted Studies at Howard University and received her Master's in Physician Assisted Studies at the University of Nebraska. And we are pleased to welcome Dr. Catherine Staffeld-Coit and physician assistant Emily Grant to Hello Health. Great to have you both with us on the program tonight.
Thank you for having us.
Dr. Staffeld, what was it or who was it that first got you interested in medicine?
As a child, I was always interested in sciences, and I had a mom that worked as a nurse and a dad who is a physician. So I was constantly aware of what was going on in the medical field, and I think it just became natural after that.
And this wasn't your original level of interest, right? How did you gravitate to this?
Initially, I thought I wanted to do primary care and do general internal medicine, but as I started my internal medicine residency, I found that I was very interested in kidney diseases, and then once I started studying kidney diseases, I found I was very interested in transplantation. So at every step, I realized I had a keen interest at the next level.
Very good. Ms. Grant, you come from the classroom. You were a science teacher, so we know you had an interest in science at some point. What made you decide to give that up and move into medicine?
Oh, I think just demand and having interest. I had a really good friend who attended a physician assistant program at UCLA and piqued my interest after being in the classroom for a while. And now, in light of the advancements in medicine and the need of mid-level practitioners, I think best decision I could have made for myself.
And just clarification of the term, because we're hearing it more and more of us are seeing physician assistants rather than physicians necessarily. The biggest difference between a physician assistant and a doctor is what?
So my formal education was for 3 years after having my initial bachelor's of science. So I was a biology major and returned to Howard to obtain my bachelor's of physician assistant studies. I was trained by physicians. And I have a medical license. I'm able to practice medicine, prescribe medications, but it is under the direct supervision of my physician staff that I work with.
Very good. Well, Dr. Staffeld, let's start with why someone would need a kidney transplant, and then we'll talk about the benefits of getting a new kidney.
The main reason people need kidney transplants is because their kidneys have failed irreversibly. There are some instances where people develop acute renal failure and they can recover and they have no reason to worry about kidney transplantation. But in the event that the kidneys do fail and the patient is left without kidney function, they have several options, dialysis and transplantation. And the statistics clearly show that patients who receive kidney transplants have longer survival and better outcomes than those who stay on hemodialysis or peritoneal dialysis, which are the other two treatments for kidney failure.
What is it that causes kidneys to go bad?
There is a multitude of reasons. In the United States, the two biggest culprits are diabetes and hypertension. And they cause damage to various organs in the body and also cause wear and tear on the kidneys that eventually cause them to fail over time.
And someone who gets a new kidney, the benefits would be what?
Well, in addition to better survival and living longer, the patients can also experience improved quality of life. They feel better, and they're also free from dialysis.
Who can get evaluated for a new kidney?
Anyone who has been diagnosed with end-stage renal disease, meaning irreversible kidney failure, is a candidate to be evaluated. And the other group of patients are those individuals who have less than 20% of their kidney function left. Their doctor has told them that they have advanced kidney disease. They have not yet required dialysis, but they're headed in that direction. So you don't have to wait to be on dialysis to start the evaluation process. You just need to be less than 20%.
And let's just talk quickly, just because it kind of brings up the question, the pecking order or waiting order for a new kidney. Is someone who has been on dialysis for a longer period of time in danger of dying going to be higher on the list than someone whose kidneys are still functioning but perhaps at less than 20%?
The organ allocation varies for each organ, and what you described is a commonly used system for allocating hearts, lung, and livers where people's lives depend on getting transplanted, and without those organs they would die soon after. Because we have dialysis, and dialysis can keep patients alive for quite a long period of time, there's not as much urgency, so actually kidney transplantation is considered an elective procedure. As a result of that, the allocation criteria varies somewhat from what it is for other organs. Time on the waiting list is a factor. Match with the donor is another factor. The presence of immunologic factors can also give you extra points on the waiting list that would put you higher in the rank order, even though you may not have been waiting that long.
Okay, and let's talk about the kidney transplant program at Ochsner, what you think makes it unique.
We have a great program that has been in place for about a year that really allows our patients to complete the vast majority of their workup in one day. They come in early in the morning and undergo a battery of appointments and testing. Emily will explain the process in more detail later. The major benefit to our patients is that at the end of that day, they will have completed the vast majority of their transplant evaluation, and many of our patients don't have to come back to visit us to complete their evaluation. They can actually have some of their studies done closer to home and send us the results, or if they're young and otherwise healthy, they may actually have completed everything they need to have done in that very first day.
This is the fast food world we're in, right? And when we're on the computer, if something takes 2 seconds instead of 1 second, we sit there and we get aggravated. Is this response to the world we live in? Is this what patients are asking for? It sounds to me this is a life-changing decision. If it took more than 1 day, that's okay.
Yeah. That's a good question. I don't think that that's what prompted us to do it. I think we were recognizing that many of our patients drive quite a long way. And we were finding that if we scheduled you for some appointments and then we told you, okay, we're going to reschedule you for other appointments, if you're driving in from Lafayette or Mobile or Pensacola, that there's a lot of gas money, travel time, and
living expenses, right?
Yes, travel expenses, gas, and we really have tried to put the patient at the center of the program. And so that's how we started thinking about how can we simplify the process to minimize the number of trips that they have to make to visit us. And by doing so, actually also shorten the amount of time from when they get referred to when they're actually listed.
Okay. Well, Ms. Grant, let's talk about the evaluation process in greater detail. Take us through it, if you would.
So our evaluation process, again, as Dr. Staffeld said, is a one-day, very focused, very individualized process. There's a medical clearance, there's a social evaluation, and the development of a financial plan. Under the medical evaluation, we obtain history, your hospitalizations, your surgeries, all of your major diagnoses, the cause of your kidney disease. We obtain blood tests, your blood type. We check your cholesterol that day. We check to see if you're anemic or what your function, your kidney function may be at that time. Everyone gets an ultrasound and a chest x-ray performed. Everyone has to have some kind of cardiac or stress test, cardiac evaluation. And as stated earlier, some people who actually require a cardiology visit, they actually have it that same day as well with a cardiologist. There's the infectious disease evaluation that entails maybe updating immunizations you may need or shots or vaccines to be prepared for transplant. And then there are other tests based on your age, your sex, and your medical condition. For example, all recipients over the age of 50 will need an updated colonoscopy, or ladies will need mammograms and pap smears. Gentlemen over the age of 40, you have to have your prostate tested. So those all entail that medical evaluation.
Okay, very good. One of those pillars you talked about is financial. So talk about the costs involved with a surgery of this kind.
If I could stress one thing, is that you would need to have a solid financial plan. This is for your life. You will be on medication for the life of your organ, so you will need to know what the cost of your medication will cover. Your visits, your copay for visits to the clinic or visits to the lab, what your insurance deductibles cover. Housing, if you live an hour away from our transplant center, we ask that you stay with us for a short period of time after transplant. So covering that cost as well. Cost for travel or gas, as Dr. Staffeld said. Food, the cost of your caregivers. You'll need individuals to help out after transplant. We say you need a transplant team. You can't do this by yourself, so you need others to come in to help you out.
Dr. Staffeld used the word elective surgery. Well, right away when people hear elective surgery, they hear, okay, well, the insurance company isn't going to pay for that. But this isn't like plastic surgery when we talk about elective surgery. Yeah. So what role is the insurance company going to play here in most cases? Well,
we have wonderful financial coordinators that actually individually research everyone's insurance availability. They tell them what additional supplements they may need, because there are some individuals that may need supplements after transplant. We had a slight discussion about Medicare disability. If you are on Medicare disability and under the age of 65 and chronic kidney disease or end-stage renal disease, irreversible disease is the primary cause of your kidney disease, you actually lose that benefit 3 years after transplant. So the expectation is that you would return to work, return to school, and we often really stress to patients that they need to have that plan together before transplant. 1 year out, where the social workers come in and talk to the individuals about making sure they have a financial plan to carry them thus further, those 3 years out from transplant.
Over the long haul, is it better financially, if I'm looking at it from an insurance company standpoint, is it, because someone's going to pay the bill, is it less expensive to be on dialysis for the rest of your life, or to have a kidney transplant where the dialysis goes away? Maybe there's more front-end cost, right? But has there been any study or analysis of that?
Yes, actually, that has been very well studied. The upfront costs are definitely higher. but actually
with a transplant.
With a transplant, correct. However, within 9 to 12 months, the costs of a transplant drop considerably, because at that point, you don't need usually more surgery. Most of our patients do very well thereafter. And the cost is really routine medical follow-up and medications. So in the long haul, it's actually considerably less expensive to manage someone with a kidney transplant than it is on dialysis.
We see commercials now where drug companies are reaching out and saying, and if you can't afford the medicine, please call us, we're happy to work with you. Have you found that the drug companies are happy to work with patients who, as part of their financial plan, might be willing to go back to work and do those sorts of things you're talking about, but might be a science teacher, where we don't pay our science teachers enough money these days. So, yet alone trying to take care of the family and provide, now you've got this additional cost of medications.
There are some programs out there for individuals with limited resources, and again, our social workers are so well versed in finding those programs. Obviously, with any additional resources in that framework, when there's limited funds, you may have to inform us sooner than later that you're in need of that, because it could take weeks to enroll you, and we would never want you to be without your medication. So that's one of the main points we home into our patients. Let us know when you need our help, because we are here for you.
You touched on the social component, but let's get into greater detail, the sort of network you're going to need to make this happen afterwards.
Oh yeah, we have a team of wonderful social workers, I think some of the best at Ochsner, that actually glue us all together. They take the patient from the beginning, the middle, and the post-transplant experience. Primarily, they educate the patient on the need for a team, the caregivers that you'll need, and that can include family, friends, church members. They educate the patient on the need for affordable housing while you're here, and they can actually give them some examples and references to places that we have locally where they could stay after transplant. Transportation is a big issue. When you get your call for transplant, you can't drive yourself here, so don't drive yourself here, because you can't drive yourself home.
You've got to get there when it's
so you have to have reliable transportation, someone to drive you while your incision is healing post-transplant, and there are other resources that they offer. Ideas on fundraising, ideas for returning to school, or seeking a new trade if you're not able to return to your previous career. So there's a lot of great resources in the social component that our social workers help with that.
Okay. Let's talk about the evaluation process, Dr. Staffeld. How does the evaluation take place?
The evaluation process begins when a patient is referred for transplant. And we actually start by doing this one-day evaluation where they do a battery of testing, and then during that day, if we find that you have a special medical issue, we might order additional tests. Once all of those tests are completed, literally we have a checklist that we run through, and
now we're in the selection process.
Yes, we're in the, yes. So the evaluation phase has been completed, and we actually have a transplant committee that meets once a week, and all of those tests are reviewed. Not just a test, but the social work evaluation, the nephrologist evaluation, the surgeon's evaluation, the dietitian's evaluation, the infectious disease evaluation. We run through all of those and make sure that everybody believes that it is safe and appropriate for that patient to continue on and get a transplant. There are patients who need additional testing, or patients who are not suitable candidates secondary to underlying medical conditions. Everybody is notified in writing of the committee decision, regardless of whether you're found to be suitable or not.
Fairness, I would think, would be a key component to all of this. I'm wondering, is the committee working blindly in having the data but not knowing exactly who the patients are? 5-year-old child versus 50-year-old male?
Actually, we do know who the patients are, and we've never used a blinded system, but we do try to instill as much objectivity into it as possible. We actually have selection criteria that our program uses, and when we meet, it's usually a group of nephrologists, surgeons, social workers, pharmacists, the dietitian, everybody on the transplant team, and of course our nurse coordinators who really put all of this together. And everybody gets to put their 2 cents worth. So I may see someone and I'm advocating that they're a candidate, but somebody else on the committee may have a concern that, gosh, maybe their heart disease is too advanced. And we have a very frank discussion when those concerns arise. And then as a group, we try to come up with a consensus decision.
And when you can't, who breaks the tie?
Actually, we don't. Usually what happens is we're unable to make a decision. And a lot of times it's because we feel that we need more information. So for example, someone has heart disease. Is it bad enough that they can't be transplanted, right, or is there something that we can do to improve their status? So in that situation, we may request that they see a heart failure specialist instead of just a general cardiologist that they've already been cleared by. But we know what can happen after transplant, and we may have some unanswered questions. So then we would tell that person that they're unable to determine, that we are unable to determine their transplant candidacy, that we would request that they see a heart failure specialist, and then after that physician or whatever other specialty we might request or additional testing, then we would bring the patient back to the transplant committee and rediscuss everything. And we're either reassured that everything is okay by the additional testing and consults that we've obtained, or it's very clear that this person is too high a risk and they're not going to be a suitable candidate.
So no 12 angry men here, more like 12 friendly, kind medical professionals coming to a consensus.
We really have the patient's best interest at heart, and there are some people that are not really suitable transplant candidates. And frankly, we might actually hurt them if we transplant them. So we take that responsibility very seriously to make sure that we're making the right decision for every individual. For most of our patients, it's appropriate to get them on the transplant list. However, for some patients, the decision may be that they might be better off left on dialysis.
And that's got to hurt, because for every decision you make where you know you're giving someone a better life, or at least that the odds say that that will be the case, you're also choosing in some cases not to allow a kidney transplant. And the human being in you says, I mean, that has to be painful in some cases, I would think.
Most definitely. I tell patients most days during the week that I get up every morning to get someone off of dialysis or keep you from having to go on dialysis. And when we meet that wall, when we know we're saying no, and it's really in the best interest for them, it hurts. It does. Yeah, and that often is not, I usually tell patients no one person gets to say no in that room. We make that decision as a team.
Absolutely.
And sometimes we walk away, some feeling worse than others, but we've made it as a team. We know it's for our patient's best interest, and we have to definitely work from that dynamic.
Dr. Staffeld, let's talk about the transplant options. There's living donors and the kidneys coming from patients who passed away, right?
Sure. The vast majority of our patients are placed on the deceased donor national waiting list that is managed by UNOS, the United Network for Organ Sharing. These are individuals that either don't have a living donor or did not want to use a living donor option. About a third of patients, sometimes a little bit more, sometimes a little bit less, have the potential of a living donor, and this is when an individual that they're familiar with steps forward to donate a kidney to them. And these are beneficial to the patient in that we know that patients who receive living donor transplants get transplanted faster. They also have better quality kidneys because the kidney hasn't gone through the process of being put on ice for a prolonged period, being shipped from one city to another, and they work better, they last longer.
They do.
And what counseling do you do? Because a family member needs a kidney right away. Oh, well, that's me. I'm happy to help. But what counseling has to take place with the donor of a living kidney to say, okay, that's wonderful that you want to help your brother, sister, mother, father, but here's what you're going to expect, because it's not as simple as going in, getting the surgery, and you're back to work the next day either, correct?
No, it is not that simple. We have a wonderful coordinator who's been doing this for years, great educator for all of our living donors. They actually really go through quite an extensive workup as well as a donor, because we have to decide that medically they would be okay for the rest of their life with that one kidney after we take one. So a lot of great detail, and in some cases we do have to send them to see a psychiatrist to make sure there's no underlying, you know, I want to do this out of some guilt response for something else. So there's a lot that goes into actually qualifying a donor to donate. Yes, so in some cases I actually had a grandmother, when we worked up, we found that she was not able to donate to her granddaughter, and she was quite upset with that. That became quite an emotional, as you said, one of those moments when I had to say no. And when she just had enough kidney function for herself, not enough for us to take that kidney and for her to be healthy afterwards. And that was quite a interesting dynamic, because she became quite angry in that room, because she's a grandmother and I'm a grandmother. So I understand, I would give my right arm for my grandchildren. So it's like, you know, to say no to someone when they're the match and they want to really do this can be quite a interesting interaction. But we do stop the workup if we find that they're not able to donate, or if we find anything that could put the donor at harm. So they're educated on all the risks. Definitely quite an extensive 2 days that they undergo a workup as well.
Well, take us back to science class or anatomy class, biology. Why do we need 2 kidneys, and how are we impacted with only one? What difference would I notice once I got past the surgery and all the healing took place? What difference would I notice? Any?
You're talking if you were
if I donated
if you were a donor, you would probably not notice anything. You would have a small incision in your abdomen where the kidney was removed, and you would live the rest of your life perfectly normally. As Emily mentioned, we put our donors through a pretty extensive evaluation. In fact, many of our donors undergo a longer evaluation than our recipients. And we really believe in the mantra, at least do no harm. We really hold our donors in very high esteem, and we want to make sure that no harm comes to them to the best of our ability to predict in the process of donating a kidney.
How do you get patients over the fear of, okay, I'm going to give you one of mine, but what if something happens to the healthy one that I still have?
Actually, we don't get a lot of patients that are fearful. As Emily alluded to, we actually get more people that are upset that they can't donate. Most people who step forward as donors are emotionally attached to the recipient. It could be their spouse, their brother, sister, aunt, uncle, adopted relative, even in some cases, fellow church members. There's definitely an emotional component that people really want to do this because they want to help someone that they care about. And our job is to make sure that they are not exposing themselves to additional harm. So actually, we end up being the bad guys in many of those cases, because we actually turn down a very large number of our donors if we believe that there's any concern for their safety.
Okay, let's talk about the surgery itself now, and if you could take us through the process of a living donation, and if you want to take us through the other one, that's fine too, and talk about the differences between the two, and you brought some images to show us as well.
Sure. So just a quick review of anatomy. We're born with 2 kidneys, and the kidneys sit relatively high in the back. And when we do a kidney transplant, we usually do not touch the kidneys. They just stay back there. Most people that go into kidney failure, their kidneys just shut down and they do nothing. Nothing good, nothing bad. So the surgeons leave them alone. To do a nephrectomy, which is a surgery required to remove the kidneys, is actually a pretty major procedure. Also, we know from many, many years of studies that people can live perfectly well with 1 kidney. So what our surgeons opt to do is to make 1 incision very low in the abdomen below the belly button. And I think the first picture shows that. The incision,
kidney's about the size of a fist, you said?
Yes.
Roughly the size of a fist?
Yes.
Give people an idea. Okay.
Yes, it's about the size of a fist. And so the surgeons make this incision low in the abdomen and attach the kidney to the person's bladder and to the arteries that supply circulation to their leg. And then they close the incision, and everything should start to improve.
Well, you sure made it sound easy.
Yes.
And what is this? And I'm going to go back and take you through the process.
Yes. So here we have a picture of a kidney getting prepared for transplantation. And you can see that It's about the size of someone's hand. If they were balled up into a fist, that's about the correct size.
How long does the surgery last? Who's in the operating room?
The surgery takes approximately 2 hours. I used to tell our patients 2 to 4, but our surgeons are adamant that most of the time they can finish in 2 hours.
Don't be in a hurry.
No.
Don't be in a hurry. Tell them not to be in a hurry.
We have a great team of talented surgeons. They've done this for many, many years. And interestingly, kidney transplantation started in the 1960s. And the technique for doing the kidney transplant procedure has not changed very much in all of those decades. So they got it right back then, and there's been very little modification to the initial technique that was used way back.
We hear about robotic surgery more and more. Is robotics used in kidney surgery, or not necessary?
Right now, it is not. However, we do use it with our living donors to remove the donor kidney, and that makes the donor procedure a much safer surgery, much shorter and quicker recovery. Our surgeons are developing a procedure where they may use the robotic-assisted technique to do transplants in heavier patients. One of the main advantages of the robot is that it minimizes the size of the incision and shortens or lessens complications and may shorten the recovery time. And for patients who are overweight, one of the major complications is wound healing from a large incision, since after all, a lot of us carry abdominal fat, and that's where the incision is placed. So that predisposes them to have healing complications.
In the case of a living donor, these surgeries are happening side by side, right? How close? Adjoining operating rooms, and are you set up for that?
Yeah, pretty close. They do have one OR room where the donor is being operated on, and the donor surgery starts a little bit earlier than the recipient surgery, but both are arranged to be in the OR pretty much simultaneously with a little bit of lag time. And as the organ is being removed from the donor, the recipient is already being readied by another surgeon, so that as soon as the kidney is removed, it literally gets walked over to the adjacent or near OR, and the recipient surgeon starts to implant the kidney because he's already gotten everything ready for that.
Is this happening at main camp? In Ochsner's case, happening at main campus?
Yes, on the Jefferson Highway campus.
Okay. What is the average wait time, Ms. Grant, for a kidney transplant?
A deceased donor or a cadaver kidney wait time, about 2 to 5 years on our list. And I should note that we have one of the shortest wait times in southern state transplant programs. For living donation, we try to work the recipient up and the donor up and have them transplanted in less than 6 months. So that's primarily the wait time.
What do qualified kidney transplant patients have to do on the front end to get ready for surgery?
As Dr. Staffeld mentioned earlier today, being that hypertension and diabetes are the #1 and 2 causes of kidney disease in the United States, controlling your high blood pressure and controlling your diabetes are the primary focus. We tell patients, if you don't get it under control now, it will affect your transplanted kidney later. Also, controlling your weight. In some cases, people need to lose weight in order to be eligible for transplant, and that requires exercise and a good diet. No smoking, no use of street drugs, and no excessive alcohol use. And I should also say that if your nephrologist or your kidney doctor has recommended that you actually start dialysis, say your function is 20 or less, and now they believe it's time for you to start dialysis, follow that doctor's recommendation. We're not going to put a healthy kidney in a toxic body. So if that is the doctor's recommendation, your nephrologist's recommendation, we would like for you to follow that, as well as being compliant if you're on dialysis, being compliant with your dialysis schedule and taking your medications as you should. So those things get you ready or prepped for transplant.
So if it was a toxic body prior, and that may be what led to my kidney malfunction, after the kidney transplant, these same rules apply, right? Can't go back to the same lifestyle that got you in trouble in the first place. Oh,
no, I would not think so. I would think you'd have to have that blood pressure under control and that diabetes under control to get the most life out of your new gift now. Because it is a gift, and so you should honor it in that respect, and that taking care of yourself, your total self, would be the first start.
And what about rejection and the sorts of things a patient can do to avoid that?
So after transplant, our primary focus is taking the medicine and taking it the way that we advise you to take it every day, on time. and for the life of the kidney. As long as the kidney is working, you're going to take this medication. Obviously, stopping this medicine could cause you to reject the organ or lose your organ. So those are the primary focus as far as avoiding rejection, avoiding infections, good simple hand washing techniques, or having hand sanitizers. One of my favorite patients is a tax accountant, and so after transplant, he had a living donor transplant. It was right before tax season, and I said, no, you probably have to do that over the phone. You have to take care of some of this over the phone, because sometimes initially after transplant, we don't want you in large crowds who are exposed to a lot of people. Also vaccinating your pets. Think about that. We love them. We're around them often. No licking in the face, no dogs licking you in the face after transplant, those kind of things. So we give them a lot of guidelines on how to avoid infections after transplant.
The kidney, it may be good for the patient, but the body doesn't want anything foreign in there, and that's what this medication deals with. Have the medications improved over the years? You said the surgery hasn't changed much. What about the medications to ward off rejection?
Yes, actually, we have seen some advances. Initially, when transplantation started in the 60s, the major treatment was a form of steroid, prednisone. And patients received very large doses of this medicine, and the side effects were pretty significant. And also, they were not particularly good at preventing rejection. In the 1980s, cyclosporin was developed, and that really markedly improved outcomes for transplant patients. Another drug, azathioprine, came along around the same time, and many of our patients were put on cyclosporin, azathioprine, and prednisone. Fast forward to the 1990s, then we got newer drugs, tacrolimus and mycophenolate mofetil, and those have taken the place, for the most part, of cyclosporin and azathioprine, although we still use those oldies but goodies. There have been some newer drugs developed too, everolimus, sirolimus, some antibody therapies that can be used, and we certainly look forward to future development. The biggest problem is that right now our patients do have to take immunosuppression for the rest of their lives. And these are very strong medicines that affect the immune system, and they carry a lot of side effects.
Such as, just so people know?
Well, the main one is because they suppress your immune system, they do predispose you to infection. And Emily, you mentioned some of the things that we ask our patients to do. Like school teachers, we expect them to have a vat of hand sanitizer on their desk so that all of their students and they get to sanitize frequently. We don't prevent them from working in healthcare, childcare, schools, but we do ask them to take precautions. Other common problems are the drugs can actually induce diabetes and can also cause high blood pressure or make high blood pressure more difficult to manage. So one of the things that we do when we follow our patients is make sure that these issues are being looked at very carefully.
Very good. We're going to take a break now, but before we leave you tonight, we are going to talk about the average lifespan of a transplanted kidney. But now we invite you to call us with your questions. 504-866-3200, 504-866-3200, or you can send us questions by email at hhquestions@wlae.com. Again, we'll be back with your questions coming in just a moment. You're watching Hello Health on WLAE.
We can beat this. The spill in the Gulf, it's a catastrophe.
But we will solve it.
This is not a Gulf Coast issue.
This is a national problem that requires a national solution.
But what can you do to help?
What do you have to offer? Your voice.
Speak up.
Add your name to the petition
Demanding restoration and protection
of America's Gulf Coast.
Sign it.
Share it.
Be the one.
We can beat this. The spill in the Gulf, it's a catastrophe.
But we will solve it.
This is not a Gulf Coast issue.
This is a national problem that requires a national solution.
But what can you do to help?
What do you have to offer? Your voice.
Speak up.
Add your name to the petition
demanding restoration and protection
of America's Gulf Coast.
Sign it.
Share it.
Be the one.
Be the one. RestoreTheGulf.com.
And welcome back to Hello Health on WLAE. Tonight we're talking about kidney transplants with Dr. Catherine Staffeld-Coit and physician assistant Emily Grant. It's been a very nice discussion, and now we welcome your questions. So let's go to, line 4, where Carrie is holding this evening. Carrie, welcome to Hello Health.
Yes, my question is, good afternoon. My question is, when you were looking at a potential recipient, how important, if the recipient has blood transfusion, or how important is the percent reactive antibodies as far as selecting a recipient?
Dr. Staffel.
Okay, those are common issues that we face behind the scenes with our patients. The caller is referring to Carrie. Thank you for that question. Antibodies are substances that your body forms when it's exposed to somebody else's tissue type. So if you get a blood transfusion, or you've had a prior transplant, or in the case of our female patients, pregnancy, you can develop antibodies against other people's tissue types. So ideally, we prefer if our patients don't have to get blood transfusions. However, if your life depends on getting a blood transfusion, you shouldn't turn it down just because you're waiting for a kidney transplant. We do have some procedures where we recommend that the blood be filtered of white blood cells, what we call leukocyte reduced, and by doing so, it actually removes the offending agent that triggers those antibodies that you were alluding to.
Carrie, good question, something we hadn't discussed yet tonight. We're glad you brought up the topic. Let's go to line 5 now. Donald is next. Donald, you're on Hello Health. Thanks for calling.
Yes, I want to know how much is that transplant medicine? How much does it cost? And does the government help subsidize that medicine, the price of the medicine?
Well, we'll take it in 2 parts. The cost of the surgery, to the level we can discuss that. We did talk about that earlier, and the role insurance companies will pay, and what role the government pays, and cost of medicine. So would you like to take that?
Sure. We have financial counselors that actually research this information based on one's insurance company. So we would have to know what your insurance is, and that takes a little bit more detail or research, sometimes on the part of the patient, but definitely from our financial coordinators. And yes, there are some programs out there that can assist with transplant as far as medications are concerned.
Let me add.
Yeah.
I would like to add something else too, and that is that when you come in for the transplant evaluation, our financial counselor and social workers actually meet with you and explain to you, based on your insurance coverage, this is what you can estimate your out-of-pocket expenses will be.
Yes.
But the short answer to your question is most of the expense of the surgery is covered by insurance. However, the out-of-pocket expense for immunosuppressants can easily run several $100s a month. And again, it varies widely based on individuals' insurance, and that's why we have our financial team meet with you individually and review your particular insurance to clarify that question.
Thank you very much for your call. Our phone number is 504-866-3200, 866-3200. We do have lines open. Here's an email we received this evening. A few months ago, my younger brother began having kidney problems. He was told has the kidneys of a 90-year-old man, although he's only 50. He's not a diabetic, however, does suffer with high blood pressure, which is controlled with medication. He's had a kidney stone in the past, which was passed with the assistance of a stent. Here are the questions. Could high blood pressure have caused this extent of a problem if it had been controlled with medication? So I guess let's take the first part there first.
Yes, we do know that well-controlled hypertension does not have to necessarily progress to chronic kidney disease. So and it's something that we preach in primary care all the time, control your high blood pressure and your diabetes so that it will not affect major organs, your kidneys, your heart, your brain. So yes, it could have been avoided with control of medication.
And let's take the second part of the question. How would I begin the screening process to see if I could be a match if indeed he would need a kidney transplant?
The process begins by making a phone call. We ask our donors to basically call in and identify themselves as being interested in donating a kidney. Our talented nurse coordinator would run through a battery of questions to make sure that all of the screening information is appropriate, that the person appears to be healthy based on the over-the-phone questions, that they're not too overweight, that they don't have any significant medical issues. We then go through a battery of testing that we alluded to earlier. It all begins with making sure that your blood types are compatible, and then a battery of tests follows after that.
Okay. Let's go back here to the next email we've received. How do I go about ensuring that my organs will be donated if I die suddenly or in the event of an accident? So this goes to what's on your driver's license, right?
Exactly. And this is April Donor Awareness Month. So, and we're here with our green and blue representing donor awareness. So yes, it's just that simple. Sign in the back of your car and letting your loved ones know, making your family aware that this is a wish for you, that you'd like to be a donor in an event like an accident or sudden death.
Okay, very good. You're a kidney donor?
Yes.
An organ donor?
Yes.
Organ donor?
Absolutely.
Okay, so not just wearing the colors, but flying them as well.
Yes.
Absolutely.
Good for the both of you. Well, we did want to talk about survival rate and how long kidneys that are transplanted last. So let's do that. And you brought a graph along that really gives us a good idea of this picture.
This slide shows kidney survival, and by survival we mean that the kidney is still functioning after a period of time. And what this slide illustrates is that survival rate at 1 year, 3 year, and 5 year is in the 90+%. So at 1 year, many of our patients, the vast majority of our patients, 95+%, still have functioning kidneys. And even at 5 years, 90+% have kidneys that are still working.
And what about after that?
The number of patients with surviving kidney transplants does fall over time, such that by 10 to 12 years, about half of patients who receive deceased donors will have lost their kidneys and or their kidney transplant function, and will have needed to either be retransplanted or return to dialysis if they were not a suitable retransplant candidate.
And what's happening? Is most cases at rejection? Is the kidney just dying a natural death? In what cases? What makes the kidney go bad?
There are actually many different reasons why that happens. Rejection is a common factor, and unfortunately, in many people, that's because they don't take their medicines like they were asked to. And in other patients, despite taking their medicines faithfully, they have such a strong immune system that they can reject. A leading cause of kidney loss, meaning that the kidney quits working, is that the patient dies of other reasons. And the major cause of death of kidney transplant recipients is actually cardiovascular diseases, strokes, heart attacks, heart failure, those type of complications, which ties back to why Emily was alluding to the importance of taking care of yourself both before and after the transplant. And we work very, very closely with our nurse coordinators who are really extremely well versed on the transplant process, and every step of the way patients are educated about what they can do both before, during the transplant process, and thereafter to help themselves. And as she mentioned, if you're losing your insurance, you're having a hard time taking your medicines because they're making you sick, or you're having any other problems with it, it's as simple as letting us know so we can help figure out what the problem is.
Very good. Well, I'm going to ask you how often you return back to your case for workups and checkups. We'll talk about that in just a moment. But we do have a caller holding. John on line 2, calling us from Araby this evening. John, you're on Hello Health.
Yes. About a year ago, I was diagnosed with gout and have been prescribed daily allopurinol. My question is, I'm 58 years old. Will there ever come a time where, because of the gout, that I will have to consider a kidney transplant?
Gout very seldom leads to kidney failure, and if it does, it's a condition called uric acid nephropathy. John, your best defense is to work closely with your physician to make sure that your uric acid level is in a target range, which the number is less than 6. If you're able to maintain a uric acid level of less than 6, the likelihood that your kidneys will be affected is very, very low. Now, one of the other common medicines that is often prescribed to treat gout, especially gout flares, are non-steroidal anti-inflammatory drugs like ibuprofen or Motrin. And if you do have any evidence of kidney disease, which your doctor should have already been screening you for if he knows you have gout, those drugs are not recommended. So stay in touch with your primary care physician and follow his or her recommendations.
Good news. John, thank you so much for your call this evening. We do have a patient testimonial we want to share with you, but first let's get to another email question. Is there an age limit regarding kidney recipients? If so, what's the youngest and oldest age for recipients?
Oh, I would not say. I think it's a relative. I had a great young lady come in. I say young lady, she was 63, to donate to her brother-in-law, and she was in great health. She never been in a hospital, normal childbirth, and so we approved her to donate. Our youngest obviously would have to be 18. We have to know that you're advanced enough or adult enough to be able to understand what you're about to undertake as far as being a donor. So 18 is our youngest age. I don't know if Dr. Staffeld has had someone older or younger as a recipient.
Ethel, are you asking about donors or recipients?
And this is an email that was
sent.
sent.
This is an email.
So it's
okay.
recipients. So sorry. So recipients, again, a relative cutoff. We do know that the majority of our recipients are over the age of 60. So the primary number of individuals that are on our list are over the age of 60.
But how many of them are over the age of 80, have already surpassed average life expectancy?
Well,
that's a very small number.
Yeah.
I would say that over the age of 68 to 70, we do start to really pay attention to the fact that this is an older recipient, and we know that even a healthy 70-year-old is going to have a harder time recovering for, let's say, for example, pneumonia. You take a 20-year-old with pneumonia versus a 70-year-old, and everybody understands that it's a different illness. So we take that into account, but we do transplant a number of people well into their 70s, as long as they're really healthy and sprightly. They don't have a lot of those associated conditions. The youngest person, I think the surgeons use more of a size cutoff. The patient has to be big enough for them to be able to accept an adult organ. As Emily alluded to, we do not accept donors that are minors. You have to be able to give informed consent to donate. So the donors have to be 18. So you're talking about putting an organ this big into an infant? Probably not. So we have to take into account the size of the patient. So most of our children have to be, I would guess, 2 to 3. We don't deal with pediatrics per se. We have a pediatric transplant team, but I know that the babies have to go on dialysis until they grow enough to be able to accept an adult organ.
Very good. Well, we did promise you a patient testimonial this evening. This is from a gentleman by the name of Mike Williams, who is from the greater New Orleans area, maybe just a little bit outside. Mark Williams, rather, I'm sorry. I believe from the Plaquemines area. And he was asked to share his story about kidney transplantation, and we have that for you right now.
I was getting out of high school at 18, and I was going to enlist into the military. And of course, you got to take a physical to go into the military. And when I went to take the physical by a urine test, they found that I had a lot of extra protein in my urine. So they told me, you probably need to go see a doctor to get cleared. So when I did, that's when I was diagnosed and made aware that I had a kidney disease called Berger's. After I found out, the doctors told me, you know, it's just something I need to monitor. It may never affect you in your life, and it could, you know, affect you 10 years, 5 years, 15 years, but pretty much just to kind of watch what you do, don't drink excessively, don't, you know, try to keep from getting sick, because that can also hurt your kidneys. Just by routine doctor's appointments and stuff, I started having some pains in my stomach inside area, and I went to a gastric doctor to go check it out. And that's when he told me, let's go see a nephrologist. They told me that it was at a point where it was pretty far gone, that if I had caught it earlier, there was treatments that they could have offered. But at that point, I was going to need a kidney transplant. It was a matter of time. And they said, we're going to go on a list, and the way the list works is it's by need basis, and they take a lot of different, things into consideration. But I came in, and my wife wanted to get tested just to see if, she would be a match. And I told her, no, you're not going to be a match. You're a little bit, I just didn't think she would be a match. So I didn't want her to even give me her kidney if she was a match. So I just blew it off, and being persistent like she is, she won eventually, and she did the test. And it came back that she was a match, and everything was good. Now that she's given me her kidney and we share that, we also have the same birthday of June 30th, which is pretty cool. We share that. So it's definitely, when everybody talks to us and stuff and tells us, wow, it's just an amazing story, it makes me realize, how much she did for me. And it's a strong relationship now for sure. It definitely has changed my perspective. It gives me a fresh start, a second chance. I'm a little more cautious of the things I do now as far as, my health. I'm more alert, more aware of what I eat, or trying to do the right things by exercise. So it definitely opened my eyes. From the lead doctor to the doctor that was my doctor for my transplant. Every time I come in, I have a nurse coordinator that's really informative, lets me know what's going on, gets to a real personal level with you, makes you feel comfortable, almost like a member of the family. It's been a great experience with everybody. Today, I'm feeling great. There's little bumps and steps, I guess, along the way, but for the most part, I'm doing great. Both me and my wife have been exercising and trying to get back to a normal lifestyle. I'm back at work. They had me back to work pretty quick, but everything's going good as far as the transplant and my health.
And we thank Mark for sharing his story with us and with you tonight. So how often would Mark or any other kidney transplant patient be coming back to see you?
In the first few weeks after transplant, the visits are once a week. As a patient approaches the 3-month time frame, we have them get labs at least once a month, but they come back to see us at 3 months, 6 months, 9 months, 12 months, 18 months, 24 months, and then once a year thereafter. And they get blood work and follow with their primary care and their general nephrologist as well.
What do you want people to leave with very quickly from tonight's program? What did you hope they would learn tonight about kidney transplants?
Hopefully would learn, if they were eligible, to know that we have this wonderful program, and we do invite them to speak with their nephrologist to be referred for transplant. Dialysis is not your only answer with chronic kidney disease or end-stage renal disease. You may be a viable candidate for transplant, and it could change your life.
I agree.
Hear, hear. We thank you both, Dr. Staffeld and Ms. Grant, for the education and information they have provided tonight and for their work in the Ochsner Health System. And we thank you for your calls and emails tonight. Now here's a preview of what's ahead with Hello Health on TV. On Monday, April 28th, we'll be back here with Dr. Kenneth Bird and certified nurse midwife Catherine Baddow to discuss new birthing options at Ochsner Baptist Medical Center. That's coming up on Monday, April 28th. To make an appointment with any Ochsner physician, including tonight's guests, or to register for any of Ochsner's Hello Health seminars, they take place almost every week across the greater New Orleans area, you can call Ochsner at 504-842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Just type Hello Health in the search areas to get started. Our thanks again to tonight's guests. Thanks to Humana and Ochsner for making this program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and our station, WLAE. Good night.
LAE has been presented by the Ochsner Health System. 850 physicians and 90 medical specialties working with a team of more than 13,000 employees provide nationally recognized health care across Southeast Louisiana. Ochsner, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want, because you deserve more.
Jackson, but nothing on the coast?
Correct. Yeah, actually, even though Jackson and Birmingham have programs for the people on the Gulf Coast, New Orleans is actually closer than driving up north to their respective programs. So we do get a lot of patients from Pensacola, Mobile, Alabama, all the way.
Got to do a quick promo. Can you all hang on just one quick minute? Okay. Anna, ready whenever you are. Okay.